Bismillahirrahmanirrahim. Today's topic is on a few very related topics like apoptosis, necrosis, and ischemia, types of infarcts, and free radical injury. All are interrelated, so I have covered them together. First, we'll do apoptosis, and we need to differentiate it from necrosis on the next page. So apoptosis, as we know, it is a programmed cell death in which the body cell, if facing any stress or a signal from within body from other cells, it will die out in a very programmed way using ATP. And unlike necrosis, in which the death is usually by the inflammatory process, apoptosis is a very clean process. So first MCQ will be, it is a programmed cell death. The other would be different from necrosis is given here that without significant inflammatory inflammation. And when looking into the necrosis, we know it is having local inflammatory reaction. So there are a few types of necrosis given here, and there are two pathways for apoptosis given here. We'll learn them. First of all, we need to know that councilman bodies named against a pathologist, a scientist, are present in apoptosis. These are basically apoptotic bodies. If we know the mechanism of apoptosis, we will learn that in this process, the cell which is about to die, the nuclear material of that cell will be clumped, that is called pycnosis. And if the nuclear material is clumped in a few centers from here, and here, for example, it will be having a basophilic stain because nucleus has DNA, deoxyribonucleic acid, and acid will be attracted towards the basic material, so it will be basophilic, and all the cytoplasm will have acidophilic in material, that is mostly proteins. So this basic histology should be remembered, that why nucleus is basophilic, because it has acid and it loves base. So characterized by deeply eosinophilic cytoplasm, because all the genetic material is now aggregated at a few places, so it will be deeply eosinophilic. The leftover will be more eosinophilic now in the cytoplasm, and basophilic nucleus because of pycnosis, the condensation of nuclear material. And then karyorrhexis will take place, that is the cutting of the nuclear material, that is by endonucleases, written here, DNA digestion by endonucleases. This is another question asked, and karyorrhexis and pycnosis both are asked. And the karyorrhexis will lead to this very specific karyorrhexis in apoptosis is making specific, because it is programmed cell death, so it will form the endonucleases will digest the DNA into some ladders, 180 base pair ladders, multiples of 180 base pair usually. So the specific DNA laddering or specific sizes of the DNA are formed in digestion process, and that is a very sensitive marker of apoptosis. So this DNA laddering is a insensitive indicator of apoptosis, and characteristics of apoptosis is this apoptotic body that is given down here, that after digestion or a few nuclear material will, and some of the cytoplasm will be pumped into a cytoplasmic bleb that forms a smaller cell-like structure called apoptotic body. This is the councilman body, in fact, specifically called, and also apoptotic bodies. The other cells around, like macrophages and neutrophil, they will engulf it and digest it without producing inflammatory response. Unlike in which a cell membrane is broken down, this is an intact cell membrane with some material, and this apoptotic body will have central nuclear material that is pycnotic and now in process of digestion, and eosinophilic, or we can say acid loving cytoplasm. So sometimes this is given as apoptotic bodies having multiple homogeneous basophilic, these are multiple homogeneous basophilic bodies because center is basophilic with a structureless acidophilic cytoplasm, or eosinophilic, because di is eosin, so it is eosinophilic. So first we studied the terminal step of apoptosis because this is important to understand the councilment bodies or apoptotic bodies and its basic structure. And then we will go to the mechanism now. That is, it has two mechanism, intrinsic as well as extrinsic. So within the cells and outside cell, and both pathways trigger activate caspases. That is the most important first step in activation of apoptosis. So here we are. Intrinsic pathway is mitochondrial pathway, and extrinsic pathway is a death receptor pathway. So in body, T cells have death receptors that they can trigger any cell to die. For example, if a cell is virally infected, so T cell, cytotoxic T cell, they are against virus. Before the virus makes its progeny in the cell, for example, in hepatitis case, in a hepatocyte, T cell will come and they will secrete enzymes, and they can have this fast ligand that can trigger apoptosis through extrinsic pathway, ligand receptor interactions, and other is immune cell, cytotoxic T cell. So ligand receptors are present on many immune cells. They can give a signal of cell death, as well as cytotoxic T cell directly releasing granzyme and perforin. This is another MCQ asked, how cytotoxic T cell will kill the cell, own body cell or virally infected cell in other way. So first step would be for intrinsic as well as extrinsic pathway. Within cell, it is if there is a DNA damage by reactive oxygen species, or by hypoxia, or by toxins, um, or misfolded proteins are there, and or otherwise radiation exposure, especially in this process is used in tumor, anti-tumor therapy, that is radiotherapy. Radiation exposure leads to activation of intrinsic pathway, and that leads to p53 activation, that is the guardian of genome p53, that usually suppresses the cell. So if it is p53 is activated, it will lead to activation of BACs and BAC. These are pro-apoptotic uh, proteins. You can say there are two types of protein in intrinsic pathway. One is pro-apoptotic BACs and BAC that leads to leakage of cytochrome C from the mitochondria. That cytochrome C is trigger of cell to initiate the executioner caspases, ultimately through initiator caspases, that is cas8, leading to the initiation of apoptosis. So this BCL2 family of protein overall, BACs and BAC are pro-apoptotic, that they will trigger a cascade of reactions starting from caspases. That is the most important first step in both extrinsic as well as intrinsic pathway of apoptosis, and this leads to leakage of the cytochrome C. And BCL2 family, BCL2 is anti-apoptotic, that it keeps these pores in mitochondrial membrane closed, so protein C won't leak out. This protein C is part of electron transport chain complex, so this is present in mitochondria. So if protein C won't leak out, it will not initiate this, and the cell will keep surviving. Sometimes body needs to make its own cell to die through p53 activation. So this p53 activation is asked, that is pro-apoptotic, and BACs and BAC are pro-apoptotic. Another is radiation, especially in radiotherapy. Another hypoxia, misfolded protein, these are intracellular signals. And pro-apoptotic and anti-apoptotic. And one important thing about is BCL2, that is anti-apoptotic protein we know here that it prevents release of cytochrome C if it has overexpression in case of follicular lymphoma that is produced by translocation of chromosome 14 to 18. Very important MCQ of follicular lymphoma that leads to decreased caspase activation. How? If anti-apoptotic BCL2 is activated, it will not let cytochrome C to come out, and won't let this initiator caspases or Cas9 to initiate the process. So cell won't die out even in the normal lifespan of the cell, so that will keep surviving. And this mutation specifically happens in certain areas, and lymphomas are produced in the body, leading to follicular lymphoma with this translocation T14 to 18. So these pro-apoptotic and anti-apoptotic proteins are important for MCQs. And if about Councilman bodies or apoptotic bodies, they are especially present in case of yellow fever and hepatitis, usually hepatitis A. So to have viral hepatitis, yellow fever also leads to hepatitis. When apoptotic bodies or specifically if asked, Councilman bodies can be seen. But if they ask the pathogenesis of in question, that would be it is seen in the pathogenesis of apoptosis. So this apoptosis takes place in case of yellow fever or hepatitis A in the liver cells, and that specifically diagnosis is given by the showing the presence of Councilman bodies or apoptotic bodies. So if diagnosis is asked, it is yellow fever preferably, and if pathogenesis is asked, that is specifically seen in apoptosis. So these are apoptotic bodies in other words. So caspases and endonucleases, two enzymes here important. So we know that it is the mitochondria that is initiating intrinsic pathways. So mitochondria is the main organelle of apoptosis. That is another question asked indirectly. And in examples, there are many examples. A few are given here, like remodeling of the embryo in during embryogenesis. A few cells die and few keeps proliferating. This is by apoptosis. And other which are asked is duct obstruction of salivary gland in case of parotid or submandibular gland leads to atrophy, and this atrophy is mediated by apoptosis. So we can say here that if there is duct obstruction, less blood supply to the parotid gland because of the obstruction of the duct, the tissue will be stretched and vessels will be stretched as well. So this is leading to this hypoxia here. So hypoxia will trigger the p53 and back and ultimately leads to apoptosis. So sometimes this hypoxic injury leads to activation of apoptosis, specifically in salivary gland atrophy. This is asked. And the other is decrease in the size of uterus after pregnancy. That is a process triggered by apoptosis. And other is radiotherapy, that is for cancer radiotherapy. So this is apoptosis. Most of things are covered here. And moving on to next page, that is necrosis. Necrosis is death of tissue mostly caused by some trauma or hypoxia. It is a very general term and it has many types. This is not a programmed cell death. This is an accidental or traumatic death. So depending upon the cause and the organs involved, it has multiple types, like coagulation of the tissue is there, then it is coagulative. If it liquefies, it is liquefactive. And if there is central necrosis that and it looks like cheese, that is caseous. And if fat is involved, then it is fat necrosis, because fat necrosis is a different phenomena than other tissue organ necrosis. And then if there are immune complexes deposited alongside, or it has a fibrin inside given here due to leakage from the vessels, it is a fibrinoid necrosis. And if there is decrease in the blood supply slowly, that leads to gangrene formation of distal extremities and GIT, etc., it is gangrenous necrosis. First, it is different from apoptosis because it has inflammatory reaction like apoptosis. Then coming on to examples, coagulative necrosis, it is just like a thing that coagulates. For example, if the blood supply of any organ, in case most of the organ like liver, heart, in case so post MI, the scenario is asked, in most tissue if the blood supply is stopped suddenly, it will leads to the inactivation of the enzymes, denaturing injury to the enzymes that are used to digest the cellular structures. So apoptosis cannot be triggered in most of the cases, and this leads to the cell to cessate in that particular environment. So the structure of the cell will not be disturbed, that the presence of cellular architecture is preserved, cellular architecture is seen. This is the question asked. So this is a coagulated cells, preserved structure in most solid tissue injuries, solid tissue ischemias like in liver and heart. We see the tissue is dead and still it is maintaining its shape. That is the best example of coagulative necrosis. And question asked about liver and heart injury. And then liquefactive necrosis. Liquefaction takes place specifically in brain, and two B's. One is bacterial abscesses, other is brain infarct. So infarct in most of the organs, liver, heart, it is coagulative. And infarct in brain, it is liquefactive, because brain liquefies. Neutrophil there releases lysosomal enzyme that digests the tissue. So in brain injury, there is no proteolysis or denaturing of the enzymes in the lysosomes, and they get a chance to leak out and digest the tissue. So the tissue will be digested, and cellular debris will be formed there, and ultimately cystic species and cavitation of the brain takes place. That is a very good finding on CT scans and MRIs. So we see the cavitations or cysts because of previous injury. So because that tissue was liquefied there, unlike a coagulative necrosis, tissue stays there. So this one pair is important, mostly due to arterial occlusions. Then caseous necrosis is a very famous example of TB, tuberculosis infection. In tuberculosis infection, it is a chronic granulomatous infection, we know. With central necrosis, it is called caseous necrosis. Macrophages surround the TB bacteria, mycobacterium, and wall off the organism, just like a foreign body is walled off, because they cannot digest it otherwise. They just wall off the organism. And then with this central fragmented cells and debris that is in the center, that is basically a depressed area surrounded by lymphocytes. They are chronic inflammatory cells, for example in case of TB, and macrophages, again chronic inflammatory cells, unlike neutrophils which are acute. They form the granuloma, a very famous example of TB granuloma. And these macrophages modify to form modified epithelioid cells, will cover it in chronic inflammation as well. So this typical cheese like caseous necrosis is seen in usually in TB. Other examples are usually not asked. These are examples of again chronic granulomatous infections. So caseous necrosis with central, just like in cheese we see a few areas of depressions and then other tissue. So this is example of caseous necrosis, TB. And then moving on to fat necrosis, it takes place in fat, and fat can be necrosed by two ways. One is the enzymatic digestion. For example, in case of acute pancreatitis, we know that pancreas digests lipids through lipases. So that lipase will move inside the body if the pancreas is damaged, and it will start digesting peripancreatic fat tissue first. And especially omental fat is asked in acute pancreatitis, that is digested, and this is enzymatic fat necrosis. Otherwise, non-enzymatic is traumatic way, in which if there is trauma to the injury to the breast or tissue that has fat in it, and that is the most common way of fat necrosis. So example asked is either acute pancreatitis, that is enzymatic, and non-enzymatic is trauma is the most common cause, that is seen in the breast tissue. that and other is seen in rumental fat and peripancreatic fat. And sponification of fat is when the calcium will be combined with the fatty acids. They have negative charge fatty acids, and they combined with the calcium they form a sponification, or just soap like appearance. In that dead tissue forms this soap like appearance. That is uh, not usually asked, but you should know that it is the calcium that is involved in fat necrosis. And then fibrinoid, the other very important necrosis. We know that the question related to fibrinoid necrosis is asked is PAN, that is polyarteritis nodosa. Um, it will be arthritis. I'll correct it. Fibrinoid necrosis is usually immune complex mediated, in which there is an immune complex deposition along the vessels, usually in cases of vasculitis. So all the examples are vasculitis, polyarteritis nodosa, or vaginal granulomatous, and those vessels will be inflamed, and the fibrin from the vessels will be leaking alongside the vessels and deposited there. So it is called fibrinoid necrosis. So the mechanism is this inflammation due to immune complex deposition there, and usually immune complex is type 3 hypersensitivity reaction, because antigen antibody both are combined, and vasculitis are examples of it. Other non-vascular, non-immune mediated vascular reactions are hypertensive emergency like preeclampsia, but it is the vasculitides that are asked in fibrinoid necrosis. And then gangrenous necrosis, gangrene of distal organ we see in the diabetic foot. The slowly the blood supply to the foot distal areas are hampered, and that leads to gangrene of the foot, that is dry or ischemic gangrene, because atherosclerotic arteries and capillaries and arterioles leads to decreased blood supply, and that leads to dry gangrene. And that dry gangrene, if superimposed with infection, it is called wet gangrene, and the superinfection is complication of the dry gangrene. So in diabetic foot, the mechanism of dry gangrene is the main cause of ischemia, and that is the most common type of most common example of diabetic complication. But the complication of this dry gangrene is wet gangrene, or the complicated diabetic foot is wet gangrene, that is with infection. So these two needs to be differentiated, that diabetic foot is dry gangrene, but complicated diabetic foot is a wet gangrene. So these can be asked separately. And now moving on to the next page 210, ischemia, infarcts, and free radical injury, three very general topics. We know that ischemia is basically inadequate blood supply to meet the demand. So the first question is asked from its definition, and one of the very reason is hypoxia due to decrease of oxygen reaching through this blood vessel. Hypoxic ischemic injury, that is called. So hypoxia, we learn about hypoxic injuries mostly. So there are certain brain tissues in the body that are more prone to ischemia or hypoxia. The first one is brain. We know that in just 5 minutes there can be reversible damage to brain. So if the question asked is most sensitive tissue, that would be brain, not the heart, because heart can survive MIs and brain cannot survive stroke, and the death is of brain is usually too early. And the other confusing MCQ asked is RBCs. RBCs can survive hypoxia. They just transmit or they just transfer the oxygen in the blood. They can survive hypoxia for much of the time. We put the RBCs in blood bank and then retransfuse to people, so they can survive. It's the brain. Given here, neurons most vulnerable to hypoxic ischemic injury include two P's. One is the Purkinje cell of the cerebellum, and other is the pyramidal cell of the hippocampus, mostly asked, also in neocortex. So pyramidal cells of the hippocampus are asked. The hippocampus is involved in memory. That's why whenever there is brain injury or a brain hypoxia or damage, the patient will forget the events because the pyramidal cells of the hippocampus are mostly affected first. And even in anesthesia or in some event where oxygen is decreasing in the body, the first thing happens is the patient will lose its ability to memorize the event. So hippocampus, memory center, and pyramidal cells of the hippocampus most vulnerable. Then Purkinje cells of cerebellum. Purkinje cells are also present in the heart that are different for conduction. Purkinje in the ventricles. These are Purkinje cells of the cerebellum. If we know the histology of cerebellum, they will be, that would be clear. So the heart, the subendocardium is vulnerable because the cardiac supply is usually, we see the cardiac blood supply, the arteries are outside the heart. So subendocardium is inside the heart. So if here the blood supplies are usually outside and endocardium inside is the uh, endocardium, myocardium is this, and epicardium is outside. So epicardial vessels are there and the blood perfused through this thick wall inside. So if there is hypoxia, the most vulnerable would be not the endocardial area because that will have direct blood for oxygen, but the subendocardial area that will not have oxygen from inside, and the arteries reaching in deep inside after division will be lost in between. And subendocardium area, this yellow area here, not the endocardium, neither the myocardium or epicardium, the subendocardium area is mostly vulnerable. So that's why if there are initially minor heart attacks called minor heart attacks, they are subendocardial infarcts, and we see ECG depressions in them instead of ST elevations, because if an ECG lead here in the heart reads this, it will be reading that infarction is on the opposite side of the heart, not on the front side. So instead of elevation, it will be seeing the depression. So mostly depressions or saggings are subendocardial infarctions. And if it is transmural, that will lead to suddenly the ECG leads in front will read it as transmural infarct or the infarct in frontal area. So it will be ST elevations and ST sagging in the opposite leads here, because they will read it as in the opposite direction, not in front of front tissue. So this is just to understand the ECG findings. I'll discuss in detail in MI and cardiac in cardiovascular system, but we need to understand why subendocardium is involved, because of the way the blood supply is there, and how this leads to damage. So it is subendocardium that is in the heart. In brain, we come here, they are neuron, two P's in heart, and there is subendocardium, and brain is the most vulnerable overall. Then kidneys, it is the PCT. If we say specifically, it is the straight segment of PCT that is present in the medullary area. So medullary necrosis is seen in case of renal tissue hypoxia usually. So it is PCT or straight segment of PCT, we can say. And in case of liver, the area around the central vein or zone 3, we know in the liver there are central zone area where there is central vein, and the three triad arteries are outside. So central area will be far away from these three arteries, and that will be necrosed first, and there will be depression in that area. uh, and then in colon or GIT, we know that main supply of the GIT is from celiac, superior mesenteric and inferior mesenteric. So there are junctions between celiac and superior mesenteric and inferior mesenteric, which share blood supply but lacks blood supply as well, because some arteries will be coming from celiac and some from SMA, and some areas might not have arteries from both sides. So these are called watershed areas, where receive blood supply from most distal branches of two arteries with limited collateral vascularities. The collaterals are not well established in between them. So watershed areas, watershed is a term you can search. It is the areas of, in case of a river or pond, it's getting multiple splies. Those areas are watershed areas. So watershed areas where there is not much collaterals in the body, and in case of GIT it is very famous areas between celiac and SMA. It is splenic flexure that is asked. So if there is damage to celiac or SMA or obstruction in there, the more chances of the infarction in the splenic flexure, because celiac reaches till splenic flexure, and above and beyond celiac flexure is SMA, and then SMA is till rectosigmoid junction, and inferior mesenteric artery takes supply beyond that. It will be cleared in GIT as well, but here it is important that these two junctions, due to watershed area in between celiac and SMA, it is splenic flexure. Between SMA and EMA or inferior mesenteric, it is rectosigmoid junction, watershed areas, and susceptible to ischemia. So susceptible to ischemia areas: neurons, hypoxic injury in the Purkinje and pyramidal. In heart, it is subendocardium. In kidney, it is BCT or straight segment. In liver, it is central area. In colon, these are watershed areas. And then moving on to types of infarctions. If ischemia or other things can lead to damage, that is necrosis. We have general two types for gross morphology of infarctions. Either it will appear red or it will appear pale. For example, we know that in Raynaud's phenomena, the distal fingers will be very much pale, because distal fingers of the hands have only one or two splies directly reaching to them, because major arteries are divide and subdivide, and only a few of the arteries or a single artery is reaching to distal extremities. So there will, if there is a blockage or due to Raynaud phenomena or spasm there, so all hand will be turned as pale. So in solid organs with single and arterial blood supply, when the single supply is turned off, it will lead to paleness of that area and leading to pale infarct, typically seen in heart, kidneys, and spleen is asked. We can edit spleen here, because most of the solid organs in the body, they have this single end supply. Kidneys have renal artery, heart has carotid, heart has its own arteries, coronaries, and spleen has splenic arteries. So the tissue will appear as pale, lacking the blood supply. We can see here in picture pale infarcts, and then we'll learn about the red infarct or the hemorrhagic infarcts. So B here, this is pale infarct. And then the red infarcts, because it happens in an organ which has multiple splies. So another question is, usually the organ with multiple supply won't have infarctions, because the other will counterpart or supply will try to preserve the organ function. For example, in liver and lungs, in liver, the blood draining from GIT, that is portal circulation, and direct supply to the liver is hepatic. So portal and hepatic both circulations are there in liver. In lungs, we know that the deoxygenated blood reaches and oxygenation takes place. This is the one supply. The other supply is direct bronchial to bronchial circulation. So pulmonary circulation is of dual supply, and liver has dual supply. And intestine, some areas we know that celiac, SMAE, and EMA, they have dual supplies there, and mostly those areas are infarcted. So there are hemorrhagic infarcts in intestines, in liver, and in lungs, and there are pale or anemic infarcts in organs like heart, kidney, and spleen. So we need to differentiate these based on either they have end arteries named after the organ and no other supply, or they have multiple supplies like liver, portal, and systemic, and lungs having pulmonary and systemic, and intestine having multiple supplies of systemic as well, two supply from systemic. And this another question is, multiple supplies have less chances to infarct, and if infarct they will be hemorrhagic or red. And pale infarct is in these end organs, solid organs with end arterial supplies, and this is a typical example, because mostly these organ will die out in case of heart attacks, in case of renal necrosis or splenic infarctions. Typical finding of infarction are seen in arterial occlusions, and these are usually of the terminal arteries in pale infarcts, and mostly they are taking place in the body. And then moving on to the very important topic of free radical injury. Antioxidants will be discussed and our reaction will be discussed with it. We know that body forms free radicals in case of injuries or damage, and those free radicals or reactive oxygen species ROS, they will damage the three main ingredients in the body. One is the lipid, that they will cause lipid peroxidation, because free radical or reactive oxygen species is usually peroxides, H2O2 for example, hydrogen peroxide. Peroxidation of the lipid takes place, and protein modifications, and the last one is DNA breakage. That is very important, we'll learn it, that how free radical leads to DNA damage and that reaction, Fenton reaction. So first we need to understand another phenomena, that is reperfusion injury, ischemia reperfusion injury. I deliberately left here. That is whenever there is a blockage of the blood supply to certain organ, for example in heart or in lungs, and suddenly after a few minutes that is released by intervention or at its own, there would be ischemia reperfusion injury. Why? Because more of the neutrophils will be suddenly moving into the organ, and they will cause damage to the endothelial cells alongside, and that will release chemical mediators, mostly free radicals. Otherwise hypoxic tissue, after receiving oxygen, that leads to generation of free radicals, and this is called reperfusion injury. So when reperfusing a tissue, one should be careful not to reperfuse it suddenly and after a very long time, because that can lead to ischemia reperfusion injury. Then free radical injury. What is free radical? Free radicals causes damage by three mechanisms, and this is the free radicals are formed or initiated by a few mechanisms. They are important, like radiation exposures. Radiation will produce during cancer chemotherapy, radiation produces free radicals in the body, and then those free radicals will damage the DNA, and the cells, dividing cells, will be damaged. This is the mechanism of free radical through free radical injury, through free radical to the cell or DNA. And we also know that radiation exposure also leads to damage by apoptosis. And then metabolism of certain drugs, not asked usually, and then we will learn about the metabolism down here, which drugs are important, and redox reactions. Redox reactions, very famous example is Fenton reaction, not given here, but it is asked, that in our body there is ferrous iron form usually inside the body, and if there are there are oxygen free radicals, there are H2O2s and other chemicals inside the bodies which are not eliminated by enzymes. They can react with this ferrous inside the body, and this is the reduction reaction, that it forms the ferric. So this is asked, ferric and oxygen free radical like OH and hydroxyl ion. So this oxygen free radical will cause damage. So if iron is in the body, it is a dangerous thing, but we have too much of iron, and if there is radiation exposure that leads to generation of H2O2, and then H2O2 will react with ferrous form the ferric form. This is the Fenton reaction of for ferrous to ferric, and free radical generation. So reactive oxygen species will form the free radical, that is the main culprit of damage, before the reactive oxygen species ROS are degraded by some other mechanism. So we learn the counter mechanism as well. So this redox reaction is important, and this WBC's neutrophils reaction is given on another page, that is oxidative burst. In oxidative burst topic, we'll discuss it in that topic. And the free radicals can be eliminated by scavenger enzymes. There are multiple ways of eliminating these free radical or reactive oxygen species just formed before the free radicals by scavenger enzymes like catalases, superoxide dismutase, and glutathione peroxidase. So glutathione injections are given for skin uh, because in skin there are multiple exposure to sunlight that causes reactive oxygen species to damage the skin, and glutathione peroxidase glutathione injections are given to restore the skin because those free radical damage can be prevented. How? By the scavenger enzyme, they will basically digest out this free radical catalase inside the human body, as well as certain bacteria, catalase producing bacteria, catalase positive bacteria. They This is the counter mechanism for them, because these neutrophil produces these free radicals like H2O2 to damage the bacteria, and those catalases inside the bacteria, they neutralize this free radical uh, produced by the neutrophil to counter it. So this is present in oxidative burst. And also catalases in the human body are present to prevent free radical injury to the body cells. And superoxide dismutase specifically in brain, this is asked, this is present in brain to prevent the oxidative damage or free radical damage. And then spontaneously those radicals can decay, or there are antioxidants just like a scavenger enzyme. These antioxidants like vitamin C, vitamin E, they neutralize these free radicals. So this potency of these antioxidants are discussed in vitamin chapter, that is GAT-CA. So most important would be glutathione, that is an antioxidant. In fact, a scavenger enzyme and antioxidant in the same category. Glutathione, vitamin E, then transferrin, here transferrin, and then vitamin C, and then vitamin A. So vitamin E is potent vitamin, and glutathione is most potent. And then certain metals carrier protein, for example transferrin. How transferrin? Because transferrin binds to iron, and we know that iron ferrous form is the main culprit behind free radical production in Fenton reaction. So the in acute phase reaction, transferrin levels are raised in acute inflammation, for example in body, to capture the ferrous form. So it is not used by bacteria in inflammatory process or by triggering the free radical damage. So this is another important body mechanism to increase the transferrin levels, that is acute phase reactant. And then moving on to the example left behind is drug and chemical toxicity. For example, acetaminophen, we know that Panadol or paracetamol overdose damage the liver. Hepatotoxic drug. Another carbon tetrachloride, CCl4, is hepatotoxic, and this hepatotoxic drug CCl4 is converted by P450 cytochrome P450 enzyme into CCl3. That CCl3 is in fact the real culprit or the free radical. This is asked, and this is taking place in P450. We know it is a mitochondrial enzyme, as cytochromes are related to mitochondria. So in mitochondria, hepatotoxic drugs are activated inside the mitochondria of liver cells. So this will lead to fatty liver or cell injury inside the liver. And mechanism of hepatotoxic drugs is asked, and especially CCl4 is a free radical. So we can cover this free radical redox in terms of redox reaction, in terms of scavenger enzymes, antioxidants in their potencies, and mechanism of free radical damage in the liver. And then ischemia through the areas and organs that are prone to it, and this necrosis in and its examples or types, and this apoptosis and its two-way pathways. So these are the very important questions and detailed explanation to the topics as well, to understand how they can be asked in exam. Thank you.